Hi, everybody. It's my pleasure to welcome you to today's webinar, Supporting the Global Evidence Response to COVID, the first year of COVIDEND. We're excited to have a number of great speakers here with us today, but before we begin, I wanted to note that there will be an opportunity for questions and answers later. Please use the chat box to ask your questions and make sure you send it to everyone or share comments during the presentations. Also, if you have any feedback after today's event, please email us at covidend@mcmaster.ca. We'll start today's discussion with Jeremy Grimshaw, one of the co-leads of COVIDEND, who will then introduce our other speakers. Please welcome Jeremy.
Thanks a lot, Stephen. So welcome, everybody. My name is Jeremy Grimshaw. I'm a senior scientist at the Ottawa Hospital Research Institute, and as Stephen has just said, have been one of the co-leads of COVIDEND since it started. What we want to do today is really it's been a fairly crazy year for all of us, but actually just reflect on what we've been doing and hopefully achieved in COVIDEND, and also what our future plans may be. I think one of the really interesting challenges about this the pandemic has been how we support personal policy and practice decisions with the best available evidence when that evidence is evolving so quickly. So I'm going to talk a little bit about the beginning of COVIDEND, and I'm also presenting on behalf of Amina El Haraka, who has been doing some work understanding sort of basically the relationships between different partners around the time of the start of the pandemic. Then we're going to talk about some early wins, and Maureen Dobbins is going to talk about the Cochrane community. Then in our language, we've been talking about moving from the sprint to the marathon. How do we make this the evidence response more sustainable and manageable, and reduce the noise? So I'll talk to that. And then in terms of current activities, Cristian Mansilla will talk a little bit about the inventory of best evidence syntheses, and Maureen Smith will talk about our approaches to or for citizen engagement. And finally, as we look to the future and look to the world coming out of the pandemic over the next probably 12, 18, 24 months, Jenn, Verma will talk about a plan for an evidence commission to think about what we've learned and what we need to do differently. So I'm going to start with just a few introductory slides. My guess is if you're here, you already know something about COVIDEND, but basically COVIDEND is a time-limited network of international evidence synthesis, guidance, and intermediary organizations that came together in response to COVID-19 to try and promote collaboration and cooperation amongst the evidence synthesis organizations and reduce inappropriate duplication of effort. And we want to do that in a way that would also help strengthen the existing institutions and processes. So that was kind of the starting point for COVIDEND. This is it's not our full list of partners. We currently have, I think, between 50 and 60 partners around the world, but these are a number of the examples, and you can see we have partners from Africa, the African Centre for Evidence, or the African Evidence Network, Australia, the New South Wales Government Agency for Clinical Innovation, Lebanon, the American University of Beirut, as well as some of the larger evidence synthesis organizations like Cochrane, like Campbell, and others. So it's a very broad tent that we brought together, and I think the key thing that brings these groups together is that we share an interest in promoting the use of evidence to inform decision making and finding ways of identifying, synthesizing, and presenting that information to different decision makers. I thought I'd give you some idea about the timeline, because in almost 20, 30 years of academic activity, I've never seen something move quite as quickly, which I think is a function of the pandemic. But prior to the pandemic, John Lavis, myself, and another colleague, Rob Reid, had funding from the Ontario Ministry of Health to provide evidence support for basically a healthcare transformation in Ontario. That was largely put on hold when COVID struck. But what the Ministry of Health recognised was our expertise in evidence, And at the end of March, we had an initial discussion with the Ministry of Health about whether we could basically pivot the resources that we've been putting into the health transformation evidence support to more of a COVID support, and they were comfortable with that. On the 1st of April, we had an internal meeting within the team, and one of the things that we were reflecting on during that meeting was that we're aware there'd been an explosion of evidence synthesis activity around the world, a lot of rapid reviews being done, often duplication effort, cutting of corners when we really didn't understand the implications of that. And so we found it was a very noisy environment to try and make sense of the research evidence. And we asked ourselves, do we think that other evidence synthesis organizations around the world share that concern and would be willing to get together to try and address this? So we ended up sending invitations to key organizations on the 4th of April, initially to attend a series of exploratory meetings, so to ask whether, do they recognize the problem, do they want to work together? And in the first week, we had 2 exploratory meetings. We had them at slightly different times of day, so we could get people from different time zones and give people a little bit of flexibility. But basically, there's a very clear sense that this was needed. And so by the 16th of April, we had COVIDEND was formed, we had the name, and we also had established a series of working groups. So it was really quite a remarkable activity in terms of the speed, but also the kind of generosity of the partners who came together, recognizing that we could probably do better if we work together globally. The initial funding, as I've mentioned, we were able to use some of the resources from the Government of Ontario that they provided. We also were able to get a small amount of money from the National Institute of Health Research in the UK and individual donors through the Centre for Effective Altruism and Fidelity Charitable in the USA. This is a donor circle that sort of basically advises people how to invest in what they think would be high return, high value enterprises such as COVIDEND. This was, quite remarkably, this is again the first time in 30 years that people came and offered to give us money without us having to go and chase it. So again, I think there was a kind of recognition around the funders and donors that this sort of activity was needed. So I'm going to talk a little bit about some work that Amina Al-Haraka has been leading, and this is we've had a series of working groups in COVIDEND, and one of them is a sustaining group. And the purpose of the sustaining group is really to sort of try and learn as we go in relation to our experiences of providing and promoting use of evidence during the pandemic. The sustaining group is led by Eli Akel from the American University of Beirut and David Goff from the Epicenter. And we were very fortunate that when we started, Amina Al-Haraka could give us a fair amount of volunteer time to help move this work forward. So the first thing we did was actually trying to understand what the situation was at the start of the pandemic. And so we basically sort of do a baseline assessment to understand the extent to which there was collaboration between the partners at the start of the pandemic, and use that as a baseline to see whether through the pandemic and through COVIDEND those linkages increased, and also to understand the initial experiences of the partners during COVIDEND. And so to understand the kind of existing networks, we did a social network analysis where we basically asked the different organizations to say, who are you in contact with? And we basically looked at different levels of collaboration. So level 2 is communicating. We're aware of each other, we talk to each other occasionally, but we don't particularly work together in a very collaborative way. Level 5 is joint collaborative projects. And if I move on, I'll just show you this. So each of these nodes talks about at least one center that identified another center that they were in regular communication with. So Epistemicus was in communication with the National Institute of Public Health in Norway, PAHO, the National COVID-19 Clinical Evidence Task Force in Australia, and you can see there's a reasonable amount of interconnection across the groups. But this is probably about 2/3 of the group. So there's about a third of the groups that were part of COVIDEND that didn't have communications at this level. But then if we ask about sort of where are we in relation to collaboration, you can see there's much fewer centres that actually are actively collaborating together. So this was a baseline at the start of COVIDEND where, basically I think we knew about each other's work, but we weren't sort of necessarily working together. And what we want to do is now, 12 months in, basically repeat this exercise and see whether there are now a much greater density of linkages for the higher levels of collaboration and work that we might be able to, or that the COVIDEND has contributed to. We'll be careful about attribution, but the COVIDEND has contributed to. We then did a qualitative study because we were interested in, first of all, the evidence synthesis organizations' response to the pandemic, how they actually pivoted in the early days, and then also why they got involved in COVIDEND and were there any early returns. And I'm largely going to focus on those two, but we interviewed 24 organizations. You can see the kind of the type of organizations and sector and region that they came from. And I'm not going to present the data in terms of what happened during the early days of the pandemic, but there's some very interesting findings coming out of that in terms of the challenges of organizations just having to pick up and run, and also being very uncertain about how long this would last for. Is this something that's going to last for 2 weeks and we'll very quickly get out of it, or are we 15 months in, still sort of, actually 18 months in, still in the middle of the pandemic? So there's some really interesting findings that just talk about how the global evidence community tried to start to address the pandemic evidence needs around a time of great uncertainty. But if we sort of want to know about, well, why did people get involved in COVIDEND? These are the sort of kind of areas that people worked through. They were interested in sort of basically improving communication, being aware of what other people were doing, sharing their work with other organizations as a way of trying to improve coordination, to reduce duplication, to basically sort of work together. But you can see also that people recognize that networks don't always work particularly well, and so there's some skepticism due to the network and issues in relation to are we just adding another basically level of complexity without getting value from that. But a commitment to collaboration and also to sort of sharing outputs and improving sort of collaboration for those outputs. So those are the kind of reasons for joining COVIDEND. And then just in the first few months, these were the kind of benefits that people saw, and also some reflections on the network itself. So it did seem that people were learning from each other, they're aware of each other's work, there's a platform for discussion and interaction with other organizations, and a real sense of engagement, partnership, and an emphasis on good quality products. And we had examples where basically partners came together to collaborate on a shared issue, or other partners recognized that actually a group in Europe was doing this really well, and therefore we don't have to do this, we can do something else. So we had a number of those examples of people changing what they're doing because they're part of COVIDEND in a way to sort of maximize the value. There were also, in terms of the structure of the network, the sense that this was a network. The ethos was very much no egos as a basis of collaboration. We had a large network, but they had organizations of varying sites, various sizes, and I hope that we've kind of worked together well to sort of think about the global good that we're providing rather than our particular niche on that. And sort of just an ethos of willingness to collaborate amongst the partners. So these were kind of what we hoped would come out of COVIDEND, and it's great that in the first few months it would suggest that the partners were seeing these benefits from this. What we would then hope to do is sort of follow this up within the next 12 months and see if there are sustained benefits and stories that we can identify of where the COVIDEND network has really facilitated collaboration and reduced duplication of effort. So I just want to highlight very quickly sort of some early wins. One of the things that we did start off with was provide a guide to key COVID-19 evidence sources. This was to say to decision makers, if you want to find high quality evidence, don't Google, but rather here's a list of maybe 18 to 20 sites that you should look at first to see if there's any that are trustworthy, high quality sources of guidelines or reviews, and that you should screen. And we know that WHO and various other partners around the world were using that when we started. We've since or significantly upgraded that, and Cristian will talk about that. Colleagues in South Africa and at McMaster developed a living hub, a COVID-19 knowledge hub, so a sort of a global map of who is doing any work in the COVID-19 space, which was very useful. We produced a taxonomy of decisions, focusing on both public health measures, clinical management of COVID, health system arrangements, and economic and social responses. This was a way of helping us organise our own work, but also I think is valuable in its own right in terms of just how people think about the range of decisions that are being made. We developed principles and resources to support evidence packaging for decision makers, a description of an evidence support model that provides responses very quickly. This is something that John Lavis and colleagues at Master developed, which is a sort of an evidence profile. And within 4 hours to 24 hours, they can respond to an evidence request to say, here's where the evidence is and here's some kind of key findings from that. Tips and tools for supporting decision makers, and then resources to support researchers who are thinking about conducting evidence synthesis. And then with Cochrane, WHO asked ourselves and Cochrane to act as a secretariat for its WHO Evidence Collaborative for COVID-19. So there's a lot of early activity. When we started out, we said to the groups, what can you do within weeks that would make a difference? And I think a number of these resources were particularly sort of helpful in relation to that. And so now I'm going to hand over to Maureen Dobbins, and she's going to talk about one of the other early initiatives that is still going strong, which is the engaging group. And Maureen, you now have control of the deck.
Thank you. Try to turn on my camera. It doesn't look like it's going to turn on. Not sure what's happening there, but so I'll just get started. So I was really delighted when Jeremy and John asked me, one, to participate in those, maybe it was the second meeting, and then when they asked myself, along with Lawrence Langer, who's from the African Center for Evidence, to co-chair the Engaging Working Group. And so I'm just going to share with you a little bit about what the Engaging Work Group has been doing. Sorry, I don't see on here.
If you go to the left-hand side of the screen, there's a pop-up. Can you see that? If not, I can.
Oh, yes, yes. Yep,
okay.
Thank you. Perfect. Thank you. So just in terms of the Engaging Work Group, really what we're about is to engage those already supporting decision makers to work in a more coordinated and efficient way. So as Jeremy indicated, we knew very early on that there were many folks around the world who were working on synthesizing evidence for many of the same questions. And we wondered if there might be something that we could do to help those in those roles become more aware of what others were doing, and perhaps if a review was already underway, then perhaps a group might choose to work on another topic. So one of the things that we started early on was the COVIDEND community, which is a listserv that has now approximately 330 members, with a focus on sharing information and lessons learned. And we're doing that through both the listserv and monthly webinars. And I see the link to actually go to sign up has now just been added into the chat, but I've provided that here and really encourage you, if you're not already a member, to go and join the listserv. Just a little bit about what the membership looks like right now. So, and this pie has looked like this, mostly from the beginning in terms of the sizes of the different groups, but primarily academic institutions, but then notably government institutions at 24%. We have 24, that's another 24% have not indicated what group they're from, and then we have 17% at non-government organizations and 3% as health institutions. And in terms of where members come from, we can see here the majority right now from the region of the Americas. There's another 85 that are unknown, but then European, African, Western, Pacific region, Eastern Mediterranean, and then the Southeast Asian is the makeup of the group right now. In terms of the membership, we know that it's predominantly the American academics, researchers that have identified themselves as being experienced in evidence-informed policymaking. They learned about COVIDEND through professional relationships, which was really fantastic to hear. From their professional role, they're predominantly involved in making recommendations and as well as in packaging. And we also asked them in a survey what their primary areas of interest were. This was back in the fall, and they were around evidence synthesis as well as issues related to public health measures. So last summer, I believe it was early July when we started when we were able to launch the listserv. And initially we were aiming for a new topic every week that we were organizing, facilitating a post as well as ongoing discussions with the listserv. We've now slowed that down. We tend to have 2 to 3 topics per month. The topics, as you can see here, this is just a smattering of what the topics have looked like. But we're really trying to address different types of methods in relation to evidence synthesis, some of the challenges that we've encountered. And then we've also used the listserv as a way to promote new resources or events that have occurred over the past year. So that's just a little bit of some of the topics. A few more, we've looked at open access principles, dissemination of COVID evidence, the difference between expert opinion-based guidance and guidelines developed using a robust process, rapid reviews. There was a paper that was written for about low and middle income countries' experience with COVID. There was a discussion led by the scoping group on the listserv. And as you see here, just a variety of topics. And we have a list ongoing for the next month. So currently the working group meets the second Tuesday of every month, and there we identify from the working group members new topics, but we're always open to receiving topics from others. So if you have suggestions for us, please don't hesitate to contact myself or Lawrence Langer. We would put those ideas on a tentative list and then review those with our working group. So some of the things that we've learned along the way about running a listserv, because I would say none of us were had too much experience as, like, let's say, the organizers or facilitators. So we've learned it's important to keep the post short, to seek that the post be around seeking input from others in terms of what they have done. So you might propose an issue, discuss how your team is dealing with it, and asking how others are dealing with that. We also are posting information items about events, as I've said. This is hard to do, but we're trying to be okay for members to observe only, as opposed to there being lots of posting every week. That can be I'd say particularly at the beginning was a bit challenging. We might post items and there might only be one response to that. But we have heard that many are happy to see the posts, aren't necessarily wanting to be having to post something themselves or respond, but are really feeling they are gaining important information by watching the posts that are coming out. We were a little worried whether or not there would be any spam or challenging behaviors, but none of that has occurred. We are using a platform that's called JISC, which is out of the UK, and it's a little bit, I guess you might say, dated, but for what we were using it for, it has actually been very appropriate and simple to use. And the majority of our members have heard about the listserv through a professional contact, which we're taking that to mean that others are promoting this to their networks, which is what we were hoping to achieve. So I'll just finish up with a few final comments about our monthly webinars. So in the fall, we then implemented a monthly webinar series. Again, the engaging work group monthly looks at or develops suggestions for new topics. We also go to the co-chairs meeting and the partners meetings and ask for ideas there as well. And you can just see here some of the webinars that we've done. We've done the Living Hub of Knowledge Hubs, and that webinar was co-branded with Gessie. We've done one on horizon scanning. We've done one that was a tour of the COVIDEND website. Probably need to do that again because there's been so much more new resources, and in fact we might have done it again. Priority setting, planning for the next phase of the pandemic, a guide to the COVID research resources for synthesis, and then looking for some of the other working groups in the coming months to be doing webinars on topics that are of relevance to them. So I'll just finish with a couple of the challenges. I mean, by and large, this has actually been, for myself, a really fantastic opportunity to be involved in this way and to really help bring this community together. But it does present a few challenges in terms of the identification of new topics. So for the listserv, we always try to have 6 to 8 topics out into the future. But we're starting to slow down a little bit in those topics. So again, ask if you have any suggestions to send them our way. The identification of topic facilitators, so looking for others to make the posts and to watch the discussion and respond. But everyone we've asked has been absolutely fantastic in supporting Lawrence and I in doing that. But again, if you're interested, it is not a task that takes a lot of time. We really have it down to, I think, a science now about how to do it. The growth of the membership has slowed over the past few months. We're not thinking that's necessarily a negative thing, but some promotion is going on because I've seen over the last 24 hours about 5 new people request to become members. We've had a few challenges in terms of increasing the number of decision makers and policy makers. That is understandable given just how busy they are, but if there's any suggestions on how we can also increase the membership on that end, we'd love to hear them. And then we're always encouraging members to feel free to initiate discussions on the listserv. That hasn't necessarily happened, but we're really open to that. And I think it's going back now to you, Jeremy. So thank you, everybody.
Yep. Thanks a lot, Maureen. And Steve, can you just give me the presentation? Thank you. So hopefully you get a sense that we got out of the gate quite quickly, and just what Maureen described was sort of within months we were developing this community and doing a range of ways of engaging with them, hopefully in ways that were adding or providing value to them. One of the other things that's happened across the last 12 months is that in general it feels like every 3 or 4 months there's basically a sort of a, we need to take stock and sort of realize where we are, what's happening in the pandemic, what's happening in the evidence response, and then, potentially, change direction. And around about the end of summer last year, we kind of recognized that we were moving from what we call the sprint phase to the marathon phase. That in the sprint phase, which is the first few months of the pandemic, there was a substantial increase in evidence synthesis and supporting activities. There were quite a lot of new entrants to the field, people who've not necessarily been that involved in synthesis previously, who were kind of moving in to do syntheses, and sometimes they were not necessarily aware of the kind of approaches or methods of synthesis. The focus on rapid reviews, largely on clinical and public health topics. Some of the challenges were that these rapid reviews, given the evolution of the evidence, were out of date within weeks. They're of variable quality. They're sometimes difficult to find. There's a lot of duplication of effort, and there's relatively few living systematic reviews or guidelines. And also our colleagues who are working in low middle income countries were experiencing significantly different challenges in terms of both doing reviews and engaging with decision makers to get their use. So it felt that when we reflected back on the first maybe 6 months of the pandemic, we had a huge noise to signal problem. And so what we started to do was to basically think about what should the future look like? And we thought for the marathon phase, what we needed was a global stock of high quality, open access, living systematic reviews that may cover, let's say, 80% of key healthcare, public health, health system, and economic issues faced by decision makers. And we've highlighted the health system and economic and social because these continue to be areas where there really is, I think, very little synthesis activity given the demand. We need to build evidence synthesis capacity to undertake these priority syntheses where high quality living systematic reviews aren't available. Local evidence support initiatives can support decision makers to find and interpret best evidence, building the global evidence synthesis infrastructure wherever possible, building on existing evidence synthesis organizations, and to secure funding. So basically what we were thinking about is we needed to move from a high noise to signal evidence phase characterized by rapid reviews, variable quality that were quickly out of date, a huge duplication of effort, find and pick your own, to a high signal to noise evidence phase, which was curated, high quality, living evidence synthesis and evidence support initiatives. And so we started to move our activities to sort of, or reposition our activities to try and promote this idea about the marathon phase. So here's some of the things we're doing at the moment. We have an inventory of best evidence syntheses, and Cristian is going to talk about that in a short while. But basically that's trying to identify high quality, up-to-date syntheses across the 4 areas of interest in COVIDEND. We've created a horizon scanning and prioritization approach where we monthly get global decision makers together on a call and ask them what are the priorities that they're seeing in terms of where we need evidence. And what we also do is ask them to prioritize that. And then we can check to see whether there are existing reviews that meet their demands. And if not, we can sort of basically, we push out a message in terms of here where we need reviews at this point in time. Maureen and Laurence are still, basically sort of driving the COVIDEND community, and she really described that. We've had a big push also to bring in citizen engagement, and Maureen Smith will say a little bit about that in the next block. So I'm going to pass over now to Cristian, and Steve, if you can give Cristian the button. Cristian.
Great. Thank you. Thank you, Jeremy. Yeah, so like my main idea of today, like here, I would also like just like to go over like what is the inventory and how can it be used, and then just like brief quick overview of like what are the main evidence syntheses that we have identified that are addressing decisions in the COVID-19 response these days, right? So this is just like a quick summary of a webinar that we conducted in March. So if you're interested in a more kind of like detailed way, you could just like visit that as well in the COVIDEND website. So basically, the inventory it's a repository of all the evidence synthesis that are related to decisions in four main areas: public health, clinical management, health system, and economic and social responses. And it's a repository where we define what are the best syntheses in terms of three main criteria, which is how recent they are, what is their quality, and whether or not they have great evidence profile in their summary findings. Once we have defined them, like we write a declarative title to make it easier for relevance assessment for users. And we also provide additional relevance for those syntheses, which includes the status, like whether or not it's living, the type of synthesis, whether it's a full review, rapid review, or a protocol, and the type of research question that it's being addressed by that evidence synthesis. In terms of like the quick methods that we use for that, we harvest evidence synthesis from high yield, high quality sources of evidence, and we extract, like by doing that process, primary data. We later assess the eligibility, and we code and appraise those syntheses like in a duplicate basis, like with two independent researchers, like discussing any discrepancies, and we include them coding their relevance for the taxonomy of decisions in COVID-19 response. That I would just like speak in a minute. And then later, like we identify the best category of those like evidence synthesis that are addressing the same decision based on the criteria that I already mentioned to you, the recency, the quality, the availability of grade, and we try to profile as much as possible living reviews, like as just like echoing Jeremy's word on that we urgently need like those areas and those type of reviews for how fast the like COVID-19 world is moving, right? And finally, we just write declarative titles, which is also like reviewed and reworded by two other senior researchers, and that's published in the website of the inventory. In terms of the taxonomy, this is just like a mutually exclusive and collectively exhaustive list of different decisions that are related to the COVID-19 response, and it's organized in these four main areas. So the first one is public health measure, which is mainly related to infection prevention and control. The clinical management, which is related to either prevent, like from the prophylaxis perspective, or to treat like COVID-19 from a clinical perspective. It's also organizing the health system arrangement, which includes like things like vaccine rollout, or also like delivery, financial and governance arrangement. And finally, the economic and social responses, which include like decisions across 20 different sectors that are grouped in these four main buckets that are just like present there. So each review that we include in the inventory is just like coded into each like specific decisions within this like four high level of categories that we have defined for COVID-19 decisions. So in terms of like what it's currently included, this figure is up to date as per last week. So like, sorry, like for not providing something more recent on this, but essentially we have identified from these high quality, high yield sources, like almost 8,000 different reviews that that like over all of our process, and just like selecting the best evidence synthesis in those areas, we have been able to provide like a bit more of 400 of those evidence synthesis, which is basically one of the things that Jeremy was like mentioning in like that could contribute to the reduction in nose to signal ratio, right? So it's like for users of evidence synthesis making decisions, it's much efficient to go over the inventory and to focus in the 400 reviews that are being profiled as best for like different type of decisions, rather than to go over like almost 8,000 reviews that are currently included in that are currently relevant and has been like harvested for like being relevant for decision making in COVID-19, right? And in terms of like what is the like nature of evidence synthesis that is being currently included in both the database, that I will speak the database as the large like kind of like set of evidence synthesis that like are relevant for decisions but haven't been classified as best in the inventory, and the inventory as the smallest, as a smaller subset of evidence synthesis that have been like identified and classified as best by our team, right? So we have like over 900 syntheses that are included in public health for the database, and only over 50 that are like profiled in the inventory, and most of them are related to infection prevention and control. Later but by far the most studied like field is like definitely clinical management, with over like 2,500 reviews that are being included in the database, and we're including over 150 in the inventory. But what is really like shocking here is that like over 50%, so half of the inventory and the database that we have currently are questions that are related to treatment of COVID, right? To clinical treatment of COVID. And which just like it contrasts with what we currently have in health system arrangement, and particularly economic and social responses. So if we go to health system arrangement, we could see that like over 600 syntheses have been conducted for that in the database, and we are only profiling 26 currently in the inventory, and 11% of the total are related to the delivery arrangement. So we don't have much on financial or governance arrangement for this. And only 200 syntheses have been identified for economic and social responses across the whole 20 different sectors that we have identified as relevant for the COVID-19. And only 30 of them, the 8% of the total of the inventory, is related to economic and social responses. In terms of this synthesis, like the currency, quality, and the living status of them, like around 5% of all the synthesis that we have included, like have searched in the last 6 months. So the rest of them have like searched like before that. So this is also related to the sprint to marathon, like the number of syntheses that were produced early in the pandemic, and how like quickly they are getting out of date, like because we don't have like like the same like volume of production these days, right? And like one of the good things of the inventory is that that percentage increases substantially, because we are trying to profile like as most recent reviews as possible. So 33% of the reviews in the inventory are like have search date in the last 6 months, and 27% of them even in the last 3 months. So in terms of the quality, like 74% of the synthesis in the database have a hamster score 4 or higher, and in the inventory that percentage is substantially higher, and where we could just like even get like more than half of the synthesis that are included in the inventory have an hamster score of 8 or higher, right? So it's just like a high quality review that we're profiling there. And in terms of the living status, we have identified over 300 living evidence syntheses that are related to COVID-19 response, most of them in the clinical side, but and we are profiling like 47% of the whole inventory of evidence synthesis is currently living reviews that we are profiling there. So just like as a final comment on the kind of like all the work that we have conducted this month, like on the inventory, like the inventory is a valuable tool to map all the existing evidence related to COVID-19 response, to also reduce the noise to signal ratio by by just like profiling the best available evidence synthesis on like given topic, and to like facilitate an easy access to those, like particularly for decision makers, right? And finally, it's also like a good way to profile living reviews, I just like showed in the last slide here. Like living evidence synthesis are mainly concentrated, like all evidence synthesis are mainly concentrated, as I said, in 3 main areas that we could define: public health in terms of infection prevention and control, and also in clinical treatment. Like we desperately need more synthesis like that, and the synthesis that we already have are getting quickly up to date. So we currently more synthesis like in health system and particularly economic and social responses, and particularly living reviews that could just like help us like keep up to date with the new evidence that has become available, right? And finally, the inventory will soon become a fully searchable database, and new added like features of this inventory could also be added to like existing databases that are not COVID related, as for example, health system evidence. So yeah, that was my last slide, I think.
Yeah, that's great, Cristian. I've got control. So thank you so much for that. So one of the things I think when we started COVIDEND, we very much were thinking about our key audiences were in the sort of public health and health system policymakers and clinicians. And one of the things that we for a few months we were sort of we struggled with was, how, what are the role of citizen decision makers? How do we support them? How do we develop resources for them? And we were remarkably fortunate that Maureen Smith basically has joined COVIDEND as the sort of the co-lead of the Citizen Partnership, working with FP Govan from McMaster Health Forum, and really has over the last sort of I think 9 months just sort of completely changed the way we are working. So Maureen, I'll hand over to you.
Thanks, Jeremy. Thanks, everyone. Jeremy, at the beginning, you put a slide up about motivations for people joining COVIDEND. So I thought I would start by just giving my motivation. When I gently nudged you and John in August of 2020 with the big lesson learned that when you nudge someone, be careful because you may end up being very involved. So I have a rare disease diagnosed in childhood. I'm immunocompromised. I'm a caregiver for my husband who has an aggressive cancer. He was hospitalized 7 times during the first months of the pandemic. So that was my personal reason for being very affected by the pandemic. I'm a Cochrane consumer. I'm the chair of the Cochrane Consumer Network Executives. I have a commitment to evidence-based medicine and to co-production, so working with consumers on evidence-based medicine. And thirdly, I'm an experienced patient partner, so I'm involved with my province's strategy for patient-oriented support unit. So when I put all that together, I thought, well, here's an opportunity. So my main goal was to have COVIDEND acknowledge that citizens are decision makers in this enterprise, and that the number of people and the number of decisions being made are unprecedented in our lifetime. Next slide. So that was my motivation. So just very briefly on what our strategy brings. So we started in August 2020, and we got our first global partners starting up in November. It does take a lot of time to get these kind of strategies going. So I had a lot of empathy for what COVIDEND did from March until August, realizing that you don't just snap your fingers and all these things appear. So we've got citizens who bring their voices to ensure that the perspective is really woven into their work. And where are the citizens? Well, they're identifying and prioritizing issues to be addressed. They're ensuring that new evidence that this is being conducted address questions and outcomes that are important to them and involve citizens in their work, and looking that the pandemic response reflects the values and insights of citizens, and also consider equity considerations and providing strategic guidance to the work of COVIDEND. Just language-wise, in Canada, we use the word engagement. In other parts of the world, you may know this as citizen involvement or PPI, patient citizen involvement. But in Canada, we use the term engagement. Next slide. So here we go. So we have citizens in the Global Partner Steering Group. We have citizens in the Secretariat, the Steering Committee, the Collaborators Group, in our Horizon scanning panels. They are present in 4 of the global working groups. There are 2 on the equity task group. We have our own citizen partnership task group that just started up, which engages our global citizen partners. And in Canada, they're involved in rapid synthesis work, including the production of plain language summaries. And I want to give a shout out to Janet Gunderson, who's attending the webinar today, because Janet is also a Cochrane consumer, and Janet and I, in collaboration with the Spore Evidence Alliance, created a 10-hour rapid review course that we've used for training. And the rapid review course is aimed at citizen engagement, so giving them a very basic knowledge of evidence synthesis and then focusing on the citizen engagement. So big shout out to Janet, who's devoted an incredible amount of time on that course. We were joking that we spent more time together in the last couple of months than we have spending time with in our homes with our husbands. So there you go. Next slide.
So I think that's back to me, Maureen. Did you want to?
Okay.
Is that okay? Sorry, we've truncated. One thing I would say is when you're nudged by Maureen Smith, you know you've been nudged by Maureen Smith. But also, this really has, I think, enriched the work we've done in many ways. It's been fabulous. So we're coming to an end. I just briefly want to mention, we've got a few more slides, that at the end of last year, we managed to get funding from the Canadian Institute of Health Research to support COVIDEND in Canada. And this provides about a third of the money is helping support the global activities you've heard about so far, and 2/3 are supporting the production of a range of living evidence synthesis or profiles, meeting the needs of decision makers in Canada. And we're working with 40 synthesis teams from across the country. A couple of things that you might want to look at is we have a number of living syntheses, one on variants of concern and vaccine efficacy, one on public health and health system implications related to variants of concern, and also one on behavioral perspectives on vaccine acceptance. So it's allowed us to increase both our Canadian relevance, but also reviews that we think are relevant to others. So the final step is, when I started, I said COVIDEND is a time-limited network. John Lavis and I would love it if at the end of this year, we could basically take the COVIDEND sign down and sort of basically just get on with our lives. But one of the things that's really important is that COVID has been an incredible stress test that's generated lots of innovation, but also identified lots of frailty in the evidence synthesis world. And it's important we learn from that. And what I want to do now is pass over to Jenn Verma, who is going to talk about a new initiative. So Jenn, why don't I just keep control of the slide deck and you tell me to advance?
Fair enough, we can advance. Everything we heard today has confirmed the pandemic has stressed the way that the world produces and relies on evidence, including a great read about this in the recent Nature News article. But we know that using evidence to inform decision makers' decisions, range of decision makers from governments to citizens and many in between, is still not routine, not in routine times, or to address slow burn issues when you think about the global climate crisis or future crises like antimicrobial resistance. Next slide. Briefly, I just want to say our commission will produce a report with recommendations on ways to better meet the evidence of decision makers. It's going to build on 3 commission reports in distinct ways. We will recognize a range of decision makers, from governments to non-governmental organizations and businesses, a range of professionals and citizens, like the Obama era commission, really targeted specific types of decisions for governments. We're going to consider the complementarity of different types of evidence. And so just recently, the G7 Science Academy released a report on data to support future health emergencies. We know that we need a broader range of evidence synthesized globally. And then thirdly, we do believe that this work can help to inform societal challenges above and beyond health or any one single category. And so most recently, the Independent Panel on Pandemic Preparedness and Response released their report, but we do think there's a broader range of challenges to address. Next slide. This just gives a quick range of the types of decisions and the types of evidence. I'll just say that from an evidence standpoint, We're examining syntheses of best evidence globally, coupled with local evidence, data analytics, cost effectiveness, monitoring, and evaluation, recognizing that these types of evidence add value in different decision-making stages. Next slide. And key to this is that, look, many societal challenges we know defy easy categorization, but some can be seen as more domestic or global, sectoral or cross-sectoral. We just really want to make the point that what we've learned from COVID-19 can certainly be more broadly applicable to health and beyond. And then finally, timeline at a glance, we've had a lot of early wins in getting out of the gate. The bulk majority of our work is happening over the course of the next 8 months. We're securing commissioners, doing the background work. And I just want to give a shout out to one of our commissioners who's on the call today, Maureen Smith. Thank you so much for taking up the call. And you can follow us on social. Our website is up and running to learn more. Thank you so much and happy birthday, COVID-end. Back to you, Jeremy.
Thanks a lot. Okay, so we're at the end. I clearly have tried to cram lots of things in, and we've only got about 5 minutes for questions. But does anyone have any questions? Steve's put a lot of stuff into the chat box in terms of links for people, but any kind of responses? So Same Mortez says, this is amazing collaboration. Are you thinking to use a COVIDEND hub and this incredible existing network to address other issues after COVID hopefully ends? So I think there's kind of a couple of issues. One is there is another organization called Evidence Synthesis International that was trying to bring together this international coalition of evidence organizations pre-pandemic. It was being done off the side of people's desks with no resources, and it didn't have the urgency the pandemic had. But Evidence Synthesis International is kind of one of our COVIDEND partners, and is very keen to sort of, if you like, keep the momentum going. And we hope that the work that Jenn described on the Evidence Commission will also give an impetus within decision-making funding sort of circles to try and support this. So we hope that this will go beyond COVID. It's just that I think that from the people leading COVIDEND, it'd be very nice if other people took the baton on. Any other questions? Okay, Steve, I think maybe we'll hand back to you if you've got any kind of questions. So I did have a slide with the various sort of URLs. If you've got any additional kind of questions or comments, then please send them either to covidend@mcmaster.ca or jgrimshaw@ohri.ca. We're always looking for feedback on how we can improve what we're doing and how we can make our work relevant to a broad range of decision makers. So thanks a lot, and Steve, back to you.
Thanks, Jeremy. I know it wasn't a lot of time for questions and answers. So like Jeremy said, if you do have any other questions or are looking for more information, please do check out our website or email us at covidend@mcmaster.ca. You can also follow us on Twitter. You can search for COVIDEND there and find us. We try to highlight not only our work, but the information and evidence being shared by our partners around the world as well. I think that is about it for today. I'd just like to thank again Jeremy, Cristian, Jenn, Maureen Dobbins, and Maureen Smith for sharing great insights with us today. And we look forward to hearing from yourselves and other panelists in future COVIDEND webinars. Thanks a lot.
Thank you.
Thank you, everyone.